Welcome to OrthoBarista. This is our third greeting. Let's learn about orthodontics while enjoying a cup of coffee, sometimes easily, sometimes with effort. I'm Senior Instructor Ji Dae-kyung.
And I'm Junior Instructor Lee Jong-guk.
Continuing from the last session, today we're delving into the second part of using wisdom teeth in orthodontics. If you have any questions while watching, feel free to leave them in the chat. We will do our best to answer, and, through a random draw, we will also send out Starbucks coffee coupons.
Can I get a coupon if I ask a questions?
Sorry about that. So, today is the second part about wisdom teeth. Last time, we discussed two patterns related to wisdom teeth. Today, we will cover the final pattern. If you look at this paper, it will help you better understand what we discussed last time and what we will talk about today. I found some relevant papers on this topic. The papers discuss factors linked to spontaneous changes in impacted third molars without angular change when the second molars are protracted. Several factors, 5 or 6, are mentioned. One noteworthy finding is that better developed wisdom teeth, or those in a higher developmental stage, tend to show more favorable upright positioning. This aligns with the cases we will discuss today and supports what we have emphasized in previous sessions.
The cases we will discuss today involve wisdom teeth with well-developed roots that are tilted forward. We'll explore how to pull these teeth upright and whether they respond well. This patient had been receiving treatment at another dental clinic. They initially planned for an implant in the 46th position. However, when the clinic suddenly closed, a situation that's becoming more common, I had to take over the treatment. I'll skip the diagnostic details for now. I suggested trying to save and use the wisdom tooth. While there was no guarantee it would work, we decided to give it a shot. The patient had already undergone 2 years of treatment at another clinic, and salvaging the tooth took considerable time. Of course, we continued with other treatment in parallel. If you look closely, we pulled the 7th tooth, but the 8th tooth, it's uncertain. Normally, you'd expect it to tilt even more. However, without attaching any appliance, it showed some degree of upright positioning after 24 months.
So, no appliance was attached to the 8th tooth for 24 months?
Yes, we attached it around that time. It had already started to come up a bit. It took a long time, but it was a prolonged case. In the next case, when the 7th tooth was pulled forward, the fibers or periodontal ligament, PDL, connection seemed to help the 8th tooth follow along nicely. But in this case, after extracting the 47th tooth, I wondered what would happen to the wisdom tooth. Would it rise as studies suggest? Or would it tilt further? It's always case by case. But in this patient's progress, after 10 months and then 17 months, no appliance was attached. Yet the root formation was complete. How does this movement even happen? I know this is a basic question, but when the permanent tooth's root is fully formed, does extracting one tooth make it decide, I'll keep going on my path?
As mentioned in the paper, I was curious whether this was strictly a theoretical conclusion or something we could confirm in practice. This case seems to provide such confirmation.
Of course, it took a long time. During that period, other treatments for malocclusion and issues related to the anterior teeth were carried out. At the 17-month mark, we began gradually upright positioning. and the treatment was completed at the 36-month mark. It took about 2 years due to other malocclusions. What do you think? If a patient had to choose between 3 years of orthodontic treatment to upright a tooth or getting an implant, what's their typical reaction?
This comparison often involves many challenges. As you mentioned earlier, there's a lot of issues. Patients often feel differently at the start and the end of treatment. Initially, they're likely happy to avoid an implant, but over time, many express complaints.
However, this particular patient was very satisfied and found the process fascinating. I couldn't guarantee it would work out as it did. But since there weren't other options, we decided to monitor the situation after extracting the tooth. Fortunately, the outcome aligned with our expectations.
The occlusal forces continue to apply pressure, yet the tooth underwent spontaneous mesialization and uprighting without tilting mesially.
In cases of significant occlusal pressure, this might have hindered eruption, but the tooth managed to upright itself to a satisfactory degree. Similar results are observed in other clinical cases, where the intraoral radiograph shows successful outcomes.
In the second image, you used skeletal anchorage, correct?
Yes, this is the case we organized after 36 months. Am I being too serious? It feels like reporting on something official.
I'm completely absorbed in this discussion.
Through various experiences, I've learned a lot. Treating cases, learning, and organizing these details seem to help me grow further. I learned so much, and new solutions to challenges often emerge. The next patient is a 21-year-old female. In the previous session, we reviewed root development, and this patient had an issue with tooth 46, which was extracted. Looking at the treatment process, tooth 46 was extracted, and we tried to pull forward tooth 7 and salvage tooth 8. However, no appliance was attached to tooth 8 for over 2 years. That wasn't the primary reason for the extended period, it was concurrent treatment for malocclusion involving the anterior teeth. Over 28 months, the tooth's behavior seemed inconsistent. Initially, it appeared to be uprighting, but as it moved forward, it tilted again. Considering this case in light of previous discussions, could the root development be a factor?
Based on the initial state, the root seems underdeveloped. If we follow the principles, mesial tilting and slower mesialization could result from underdeveloped roots.
Ultimately, this case took 38 months. At the start, I thought, the root hasn't developed yet, so it should align well, but it was more difficult to control than anticipated. In contrast, cases with better root development tend to show better uprighting. There's supporting research for this, too. Time is often a key factor. After 2 years, patients typically grow weary of treatment. Although this case eventually achieved the desired outcome, it underscores the importance of careful planning and consideration. Here's another similar case, which I'll briefly discuss. In this case, look at the 30s region. We tried to salvage tooth 8 by pulling tooth 7 forward. If you examine closely, you'll notice tipping occurring here, along with TFO. Tipping occurred, but the wisdom tooth emerged quite smoothly. Its roots seemed to develop further, becoming more defined. Efforts were made to upright the tooth, correcting the slight tilting of tooth 7 and aligning tooth 8. This process took 40 months. The patient didn't return after the 40 months mark.
The patient stopped coming for follow-ups.
I was curious about the reason. Perhaps it was due to circumstances and not dissatisfaction.
As mentioned earlier, teeth adjacent to the sinus wall are particularly challenging to manage in terms of tilting. Nevertheless, in the cases presented by Dr. Lee Jong-guk, the retention results appear promising. Even though the patient hasn't returned in over 4 years, I'd expect the retention to be stable.
Retention is always a point of curiosity. While we didn't go into detail about the 20s region, deciding whether or not to pull those teeth further involves careful consideration. Should we invest more effort or not? These are questions worth discussing together.
From the perspective of functional occlusion, it seems the alignment was achieved.
The next case involves the maxilla, where the patient had a forward tilted alignment. About a month ago, they had tooth 27 extracted at another clinic due to issues. They were advised to visit an orthodontic clinic for further evaluation. The patient also mentioned that their front teeth seemed slightly protruded. The photo of tooth 28 was taken a month after the extraction of tooth 27. At the time, the roots seemed well developed despite being embedded. You might wonder whether this adult tooth could emerge fully. Surprisingly, as I'll show in other cases later, it emerged quite well. It emerged reasonably well, though luck may have played a role. For cases where the tooth doesn't emerge, things can become quite complicated. In this particular case, the extraction of tooth 27 was necessary, which was fortunate. Otherwise, attempting to extract with the hope that tooth 8 would emerge could have made the process more challenging. The case I just presented is one where the tooth did not successful as expected.
There's also a case where no further pulling was required.
This patient provided valuable information, but had to travel abroad during treatment. Even after returning to the country, they only came in for follow-up once or twice a year. The treatment was quite challenging due to this, but we recently completed debonding. You might be surprised by the duration of the treatment. If you were to diagnose this case, what kind of treatment plan would you have devised?
Having seen so many cases requiring pulling, I've gained confidence in persuading patient to proceed with similar treatments. For instance, pulling teeth 17 and 8 forward, then addressing tooth 47 if missing, and possibly pulling tooth 48 into position. In addition, extracting tooth 36 in the periapical lesion and pulling teeth 37 and 38 forward might have been considered. Was your plan similar?
I proceeded with a similar approach. In reality, patients with issues in the 10s, 20s, 30s, and 40s regions all face significant challenges. For the 10s region, the key seems to be whether the wisdom tooth will emerge properly. For the 30s region, will tooth 38 come out well? As for the 40s region, it's likely ankylosed.
Typically, that's how it appears. I would lean toward extraction rather than attempting movement in such cases.
Let's take a closer look at this case. There were some issues, and the crowding in the front teeth was severe, especially in the maxilla. Once premolar in the maxilla was extracted. After extraction, the treatment progressed. During the first 8 months, the patient was unable to visit frequently. Initially, the focus was on relieving the maxillary crowding. At the 16-month mark, a window opening was performed for the 40s region. There was curiosity about whether the tooth would emerge. At that time, the patient was still in the country. Regarding tooth 38, I assumed it would naturally follow if tooth 37 was pulled. By the 24-month mark, 2 years, the patient suddenly stopped coming. At 24 and 32 months, the patient mentioned needing to stay abroad for a year, so all treatments for the 40s region were halted. To avoid complications abroad, we decided to leave it as is. At the 44-month mark, nearly 4 years, the patient returned to the country. We decided to attempt pulling the tooth and proceeded diligently. By the 58-month mark, progress had been made, and eventually, 83 months passed. How many years into your practice are you?
I'm currently in my 26th year. 26 years? Since opening your practice in 2004, it's been about 18 years, hasn't it?
Yes, 18 years. I'm in my 10th year of practice.
Considering that, you've gathered truly remarkable cases.
This case, in particular, involves tooth 38. And since the patient didn't visit regularly, I didn't consider pulling the tooth. Frequent visits are essential for such procedures, but the patient could only visit about twice a year, sometimes not at all for a whole year. Seeing the results, I've learned that some wisdom teeth, like tooth 38 in this case, simply don't emerge. Until this case, I had assumed they would always emerge eventually. Although surgical interventions like window opening could have been attempted. The patient expressed satisfaction with the current state and declined further procedures. This raised the questions: is the tooth completely immobile?
Academic papers often carry a degree of bias, but comparing this case with others we've reviewed reveals a somewhat contradictory outcome. Even though tooth 38 didn't emerge spontaneously, had the patient visited more frequently, perhaps Dr. Lee Jong-guk could have attempted to pull it.
Observing closely, there may have been slight movement in tooth 8, but it's unclear.
For tooth 38, the oblique edge area appears slightly more open. Depending on the angle, it could be perceived differently.
Based on tooth 48, there's a possibility of movement, and I plan to monitor it further. If the patient agrees, we might approach it later. Lastly, here's another case with a similar background. In this case, orthodontic treatment was performed due to the impaction of tooth 23. There was a congenital missing tooth in that area. Talking about this case could take all day because there's so much to explain. I spent about 4 years pulling an impacted tooth into place, but I left tooth 18 alone for a while. Looking at this patient's case, tooth 7 should have moved forward and helped bring it down. But there's also a 72-month photo I didn't include because it might be too shocking. Instead, I've prepared images up to the 56-month mark. It's unclear if the wisdom tooth is ankylosed or delacerated, as it doesn't seem completely immobile. But I'm not certain. We might need to actively pull it out. But the patient has already undergone 3 or 4 significant luxation procedures for the impacted tooth, which caused a lot of discomfort. They didn't want to go through it again, and I didn't want to cause further distress. Ultimately, I realized that not everything can go according to my plan. This has made me more cautious, and I now ensure to give thorough explanations and document everything defensively in the chart. It seems that this approach has become more important. Getting the patient's consent for such cases is crucial, and reviewing cases like this emphasizes its importance.
Could it be related to primary eruption failure or ankylosis?
While the exact cause is often unclear, it could be one of those factors. It might still be possible to attempt extraction.
But this was the first case where Dr. Lee Jong-guk decided not to pull the tooth.
Including this case, there have only been 2 such instances.
You've now seen the series of cases related to wisdom teeth. These are not always straightforward cases to manage. From the perspective of an orthodontist, these cases are not easy to approach, whether or not the patient has specific needs. However, I believe it's helpful to consider these options and the mechanics mentioned earlier as references. Here, you can see a recent 2020 article from AO. It discusses factors that can influence the spontaneous mesialization of the mandibular third molar during protraction of the second molar. The study found that approximately 86% of the teeth succeeded in mesialization. The study highlights the factors affecting this process. Patient age, gender, and the angulation of the wisdom tooth were reported to have little impact. However, we observed from earlier cases that factors like the maturity of the wisdom tooth root, based on knowledge stage, play a significant role. The more mature the root, the better the mesialization. When protracting the second molar, a gradual approach, pulling slowly, seems to work better. It is hypothesized that this might be due to the tensile forces on the periodontal ligament. The results align with this, showing that the angulation of the wisdom tooth doesn't strongly correlate with the outcome. Some studies conclude that angulation isn't a major factor. As mentioned earlier, while these findings are not absolute, they provide useful insights. From my perspective as an orthodontist, this case was not easy to approach. It was an exceptional and valuable case, and I'm truly honored to have been involved with it.
This demonstrates what is possible, not what must be done.
Next time, we might consider widening the gap for an implant rather than pulling the teeth.
I'll stop here for now. In the next session, I'll present more interesting cases.
The title hints at saving teeth.
But the goal is to show the versatility of orthodontic approaches, how things can work one way or another.
Please look forward to it. This concludes the third Ortho Barista. Have a sweet afternoon, and I hope you enjoy your afternoon consultations.
Thank you.